So nice to meet everyone. Thanks for your time this evening. My talk today is really about soft tissue knee and young adult knee preservation, and basically that's what I spend all my day doing. I'm going to show you this slide right at the. Bear with me. I'm just making sure that you can all hear me. Apologies. Right. So this slide is an important slide. I'm going to share it with you throughout the session, at the beginning and at the end. And this slide is not actually my slide. It's actually from is where we need to keep the patient to prevent them getting into the amber phase. So what do we do with the young adult knee? You know, those patients who are too young for a total knee replacement, they're too far gone for an arthroscopy. What are our options? So we've got osteotomy, we perform ligament reconstructions, meniscal repair and allograft transplants, and osteochondral allograft transplants. Now, there's different indications for a lot of these different operations, but for example, meniscal allograft transplants, you can't jump straight to a meniscal transplant unless their alignment is correct and unless they've got a stable knee. So this is very much the ladder that we kind of use as a young adult knee preservation surgery. Alignment is first. You have to have a stable platform, have the knee stable with the ligaments, whether it's reconstructed or whether it's native ligaments. Then you have to have the menisci, which are stable before going on to the chondral surface. So alignment, ligamentously stable, meniscal apparatus intact before proceeding to chondral surfaces. And obviously, if all those three are fine, then osteochondral allograft transplants for significant chondral defects are a surgical option. So with regards to the assessment, so it's very important when you're assessing these patients is where is the pain. Patients obviously can be very vague, but more often than not, they know exactly where their pain is, and you have to clarify that. And if they've got medial pain, is it over the MCL? Is it over the medial joint line? Is it over the origin of the MCL, or is it over the insertion? I do a lot of MCL work with my ligament reconstructions. Sometimes the MCL is pulled off the insertion on the tibial side, and I have to reattach it. Likewise, if it's a mid-substance MCL tear, I do a lot of internal bracing where I do percutaneous surgery to get the patient going, as opposed to leaving them in a brace for 8 weeks. They end up with stiffness, significant quads wasting. I'm sure, as you all know, if you keep the knee in a brace, preventing extension, the knee is not going to be able to engage the quads, and they'll get wasted away very, very quickly. So location of the pain is incredibly important. Generally, if they've got an effusion, that's a red flag from my point of view. When I'm in the acute knee clinic and they've got an effusion, they're getting an MRI scan. Obviously, we're going to take history and examine the patient, but ultimately, if there's an effusion, they've had a catastrophic event in the knee, whether it be an ACL rupture, a meniscal root tear, or any form of chondromeniscal pathology. If they've got a fixed flexion deformity, have they got a bucket handle tear of their meniscus? Again, is an urgent MRI scan. And there's no point doing, especially for patients who are in between 15 and 30, urgent MRI scans are certainly required. If the knee is unstable, likewise, it needs a further assessment and assessing where their instability is. Is it medial lateral? Is it AP? instability, and don't ignore the paediatric knee. Since starting in Kingston in July 19, I've started up the paediatric and continued the paediatric knee services, where we've increased our referral base. We've set up a pathway through day surgery, and we're starting to receive a lot of referrals across the region. And unfortunately, they're a difficult cohort. Parents are difficult as well. These kids are obviously in their high level athletes, getting very dedicated into their sports very early in their life, and they want results. And again, sometimes the MRI scans are normal, and it really is based on the clinical examination. And it depends who's reporting your MRIs as well. I saw a child, 15-year-old, who was involved in a rugby tackle in November. Saw them yesterday. MRI was reported normal. He's got clear posterolateral corner injury, so I've listed him for a posterolateral corner reconstruction, and parents are happy. So it really is all based on the history, on the examination, and don't rely on the MRI reports. Half the time they're outsourced into random other companies, and you're not going to get a dedicated musculoskeletal radiologist giving you the report. So very important that you can get to look at the images and correlate that with your clinical findings. A little bit about imaging. I'm sure Bobby talked about this previously, but can't stress, if you're ordering X-rays, make sure that they're weight-bearing X-rays. Really from the, if you're kind of investigating the 30-year-old onwards with the meniscal pathology or any chondral lesions, you really should get some weight-bearing views. And this is a weight-bearing AP view. And just to show you the difference, this patient was complaining of lateral-sided pain. You can see the Rosenberg view, where, just put my mouse here, you can see this is a striker notch view, and this is with the knee in the fully extended position. So obviously we're not functional in the fully extended position. We're obviously, when we're walking, we're going up the stairs, the knees flex at 20 degrees, and really you can see he's already down to bone on bone on that lateral side. And likewise, again, this patient, again, standing fully, you can see there's some sclerosis and some femoral condyle hypoplasia of the lateral compartment. But really, when you perform the striker notch view or the Rosenberg view, there's a tilt on the X-ray machine. You have to specifically ask, you don't want overlap of the joint, so you can actually appreciate what's going on in the joint surface. And you can see he's got some avascular necrosis of the lateral femoral condyle. So common presentations, really meniscal pathology, chondral pathology, and ligament ruptures. Differential diagnosis, really, if it's traumatic, is it the meniscus? Is it the joint surface? Have they ruptured their ligaments? There's obviously other acute differentials which you need to be aware of, things like gout, pseudo-gout, which I'm sure you are, infection and bleeds. And in the chronic setting, is it the degenerative meniscal tear? Have they got chronic chondral damage, chronic instability, and end-stage arthritis? So with meniscal pathology, the symptoms, they're usually fairly acute in onset, and they even can have benign trauma. I'm going to be talking to you about meniscal root tears in the latter part of my presentation, and trivial injuries, even just stepping off a pavement, that twisting movement of the femoral condyle on the posterior aspect of the medial meniscus, it can be devastating. So it's very important to get a clear history and really understand about the onset. If they've had pain for the last 10 years, this is unlikely to be a repairable meniscal tear. If it's sharp, well localized catching, if it's sharp stabbing catching, that may involve a flat tear which can get caught in the medial gutter, and they can do very well with arthroscopic surgery. Swelling and instability obviously need to be noted, and locking, and again, the sharp, painful stabbing and catching is incredibly important. Once again, with regards to the signs, and effusion and pain on full flexion. Joint line tenderness for me, I don't really do McMurray's quite honestly. It's joint line tenderness where the pathology is. So this is just a kind of an acute knee, and a demonstration of an acute knee pathway, which I'm sure you've all got in your own emergency departments. But generally, if they've got an acute injury, have they had a twisting injury? Was there a sudden pop? Was there a locking episode? Was there a dislocation? And if it's yes, obviously we have to see if there's an effusion, if they've got reduced movement, and is there difficulty weight bearing. If any of those are positive, they really should go to the acute knee clinic. You should have access to your rapid knee clinic within 48 hours so they can get assessed by a knee surgeon. And if there's any evidence of any tibial plateau fractures, lipohemarthrosis, obviously it's going to go to the orthopaedic on call. So the main topics I'm going to cover really are osteotomy and meniscal root tears. I understand Bobby gave you an extensive talk on arthroplasty and some osteotomy work. I deal with a lot of osteotomies throughout my day, so I'll give you a bit of a insight into what I do on my day-to-day. And I'm going to give you a talk about meniscal root tears as well. If you look about the interest in osteotomy since for the last 7 years, if you look at the hits from 2014, there was just over 500,000 hits in knee osteotomy on Google. If you look at 2021, there's just under 3 million hits. Obviously, all the other numbers have gone up as well, but osteotomy certainly is certainly increasing. And obviously, everyone is understanding the benefits of osteotomy as opposed to arthroplasty. Osteotomy has been performed for centuries, dating back to Hippocrates in 460 BC, and it was clearly stated the most spongy bones consolidate quickest, and that's why we do the osteotomy in the metaphyseal region. And there's some pretty barbaric pictures there, which is not really what I perform in my theatre. So how do we achieve good outcomes? It's all about patient selection, as a lot of things are. Planning, which is the most critical thing, surgical technique and modern fixation devices, and the rehabilitation. So the role of osteotomy around the knee, we can unload the damaged areas in the knee, we can retension ligaments and correct post-traumatic deformities. Patients with tibial plateau fractures that have been neglected or fixed, in a not ideal fashion, they can be corrected with osteotomy, and it can be used as an adjunct to other procedures. So I do a lot of simultaneous ligament reconstructions with osteotomies. And the things that influence the outcomes: age, gender, activity level, and expectations. Someone in their 50s who want to continue skydiving and running a very high active life, if you put a joint replacement in them, they're never going to be able to get back to that level of activity. The ideal candidate previously was below 50. I've extended that to below 60 now. I have to say it's fairly rare to do an osteotomy in the above 60 group. Previously it was male, but the UK knee osteotomy registry has shown that's actually not the case. Actually, females have actually, in terms of their Oxford knee score, their KOOS and their Tegner at the 2-year mark, actually are better than the males, which is fantastic. BMI, previously again was 30, that's been extended. Manual workers obviously want to get back to high level of activity, and smoking is a big no-no for me. So this is just a demonstration in terms of the BMI. When you do a knee replacement, that's going to be a very difficult knee replacement. Not saying the osteotomy wasn't difficult, but patients preserving their own knee joints is incredibly important. So what we looked at the Oxford knee score in relation to BMI pre and post in the males and the female group, and you can see the purple line is the post-op line, the blue line is the pre-op line, and obviously the to the left of the graph are the lower BMIs, and to the right of the graph are the BMIs above 35. And you can see the improvement in the Oxford knee score is maintained throughout the BMI groups. So indications in terms of physiological age and activity, I have to say mean age for a partial knee replacement from my point of view is the mid-60s, and for an osteotomy it's certainly a lot earlier, and that is in the mid-40s age group. And the HTO by outcome, once again, patients are still very happy. If you look at the Oxford Knee Score and the KOOS, even in the above 60 age group, it's certainly more is maintained even at the 2-year mark. So the advantages: preservation of the natural joint, the ligaments, the chondral surfaces, no one's interfering with the knee joint, immediate weight bearing, we're not burning any bridges. There's a significant dissatisfaction. If you look at the UK joint registry, 5% of patients are generally dissatisfied after a knee arthroplasty, whether it's to do with the tibial rotation or the external rotation of the femoral component. A lot of these things with the traditional instrumentation can be very, very challenging to get absolutely perfect. And people wanting to maintain a high level of activity, it's a no-brainer. So I'm just going to show you a quick video of how we perform the planning. So we've got the weight-bearing axis from the center of the femoral head to the center of the talus, and we apply a little hinge point, which is just there on the proximal part of the fibula. And then we have to enter the hinge point and imagine where we are actually going to sit directly into the hinge. And then we have to work out what that angle is between our destination and where the Mucklitz point is, and that's where we want the osteotomy to sit. And this is called the Miniaci method, and you can do it with trigonometry. You can do it on TraumaCAD, which is a preoperative templating software as well. So this is a case of mine recently I performed. This is a guy in his mid-50s. You can see his weight-bearing axis again, center of the femoral head to the center of the talus, passing well to in the medial compartment. He's had an MRI scan. This is the T1 weighting image, coronal imaging. You can see on the lateral side, he's got fantastic chondral surfaces across there, good meniscal tissue. And over on the medial side, there's really no meniscus at all. He's had a previous meniscal resection, and the chondral surface is obliterated. So he goes through the TraumaCAD planning software where I calculate the MPTA, which is the medial proximal tibial angle, and the lateral distal femoral angle amongst other angles. And then I'll calculate exactly where the osteotomy is best performed, whether it's best performed in the tibia or in the femur. So the osteotomy is performed through a 4 centimeter incision. I'll just show you a quick video of that. K wires are passed. Osteotomy is opened through the Hinterman. This K wire is passing through the hinge point to protect the hinge. The femoral head allograft, which I'll come to in a second, is passed into the osteotomy, and the osteotomy is fixed with plate and screws, and it allows immediate weight bearing. So I'll just show you a small video. This is a 4 centimeter longitudinal incision. This is the femoral head allograft preparation, which we get these already pre-cut, prepared allografts to save time. But whilst I was on fellowship, we were preparing these from femoral heads, and we would essentially prepare the femoral head according to 0.01 millimeter accuracy. This is a precision saw blade, which is incredibly safe in the right hands, and we're preparing the femoral head allograft. And this allograft is a real game changer. It's allowed really early weight bearing, reduced swelling, reduced pain. This is the stacking osteotomes to open up the osteotomy, and you can see there the osteotomy is opened, and the plan is to pop the wedge in, and there's a little bit of brutal force to try and get the femoral head into the osteotomy to maintain that correction. And you can see there the osteotomy has been opened. You have the Synthes Tomofix plate maintaining the correction, and that is an osteotomy on the medial side opening wedge. So what about the outcomes? How good is the surgery? This is 10 years, 80% survival. There's papers going up to 18 years. It obviously does tailor down with progressive arthritis, but the outcomes are fantastic. And the literature is there for anyone. I've got these articles, and I'm happy to distribute those. So meniscal root tears, obviously taking a slight U-turn, but these are so incredibly important. Not a lot of people know about these. I'm sure you're all fully aware of them, but this is essentially a silent epidemic. The meniscus itself, the structure, as you all know, there's circumferential fibers going all the way from the root attachments into the bone. You have the radial fibers which are attaching the meniscus, and the anatomy is so critically important to its function. It works as a load distributor, and it's based with having those two attachments of the roots inserting into the bone so that we can reduce the contact loading stress in the joint. You can see here what I was alluding to. This is a cross section. You can see the medial meniscus across through here. This is the anterior meniscal root. This is the posterior medial meniscal root attachment. And you can see the circumferential fibers going in across through here, transmitting into the bone. Now, if we put it all together and we just demonstrate the, bear with me, if we just demonstrate what the knee actually looks like, the meniscus is there to provide stability. It's there to provide joint distribution, to distribute the joint loading and the joint forces. And I'll try and draw quicker, but essentially you've got the meniscus on the medial and the lateral side. Then you have the circumferential fibers which are passing through the meniscus. And I'm not going to apologize for repeating this. This is all critically important. And you have the radial fibers which are holding that in place. Now, when the knee is loaded, the forces are going through the meniscus and not the cartilage surface, and essentially it's being distributed all the way across those circumferential fibers and being distributed into the bone. And that's why we don't develop arthritis when we walk. Now, again, if you look at the cross section here, you have the attachment at the posterior root and the anterior root, and you'll start to see that if I bring that along a little bit. So you have the circumferential fibers which are passing through the meniscus, and the radial fibers. And then the weight, when the weight is applied, it transmits through the bone. So that's what we're relying on. Now, what happens when we have a meniscal root tear, where you have essentially a transection, a massive radial tear at the posterior meniscal root? What actually happens is the meniscus is extruded out of the joint. It's like having a total meniscectomy, a sudden onset of a total meniscectomy. And what happens is the meniscus is spat outside of the joint, and the cartilage on the medial side of the femoral condyle and the tibial condyle, there's a massive increase in the loading pressure in the knee. The knee thinks, geez, what's happened? All the cartilage starts to break down. You get microtrabecular fractures, and that's where you get this condition, the spontaneous osteonecrosis of the femoral condyle. This is all a spectrum. You don't just get spontaneous osteonecrosis. This is all a result of a meniscal root tear. You get trabecular fracturing, and you get progression of arthritis. The reason you get this tear is because the posterior root is the most immobile part of the meniscus. And who does it happen in? It happens in kind of the fifth decade of life, maybe tail end of the 40s, but I see it in the 50, 60-year-olds. And this is essentially people who are previously absolutely fine. And the keys in the history, they were absolutely fine. They've had a trivial injury. They were coming down some steps. They just missed a step, or they jolted their knee. They had a sudden popping sensation in the knee. They've got a massive effusion. They can't weight bear because of that sudden onset increase in pressure in their femoral condyle and their tibial condyle. There's microtrabecular fracturing, and they can't tolerate it. And this is a case series. I always show this in my meniscal root tear presentations. And this is a case series over same patient over a 6-month period. They had this presented in A&E, where they've essentially done a weight-bearing x-ray of the knee, and she's had progressive x-rays just demonstrating the narrowing of the medial compartment over a 6-month course, and then obviously went to a uni. However, if this patient was identified, their index of suspicion was high. They've had a gold standard MRI scan. Just bear with me. If they've had a gold standard MRI scan, and it can clearly show the meniscal tear. You see on the coronal imaging here, you have a radial tear at the posterior root. On the sagittal T2 imaging, this is called the ghost sign, and the axial image gives it fully away. You can see a full transection there. So what I do, I identify those patients and I repair the roots. I do it arthroscopically, and essentially I go into the knee. I debride the actual insertion to get it back to some bleeding bony edges, and then I pass some sutures into the back of the meniscus. I create 2 small tunnels in the back of the knee, and then I bring those sutures down and hold it in position. Now, my rehab following this surgery is very aggressive. I'll just show you, this is a small video while I'm talking about the rehab. And this is any sort of passer that you can pass. There's numerous on the market, but you're passing the suture through arthroscopically into the meniscus and passing into good quality tissue. You have to treat these patients aggressively with regards to their rehab. You have to really treat them with non-weight bearing for the first 2 weeks, and then progressive weight increase in their weight bearing from week 2 to week 6, because essentially you're getting that meniscus to heal back onto bone, which is actually a pretty impossible task. But these suture, James Robinson from Bristol has done anatomical studies of where these ultra tapes, where it's actually best to pass them in the meniscus, where there's most collagen fibers to get the best purchase. And I'm just going to show you this just to finish off my talk. And really, this is really where we're headed. We need to keep the patients in the green zone, prevent them getting into the amber, which is evidently going to prevent them getting into the red. The major complication risk after a revision knee replacement is 20%, and that is deep infection, amputation, patellar tendon and extensor mechanism issues. So keeping the patient in the green, preventing them getting into that amber zone is the best thing that we can do. Thank you for listening. I'm sorry I talked a little bit fast, but if there's any questions, I'm happy to answer them now. And that is my email address, and happy to take some questions.
Right, I'm just having a look in the chat function. I haven't got any questions. Oh wait, there's one in the questions and answers from Ali. Should we be considering using unloading bracing more?
Definitely. I think the offloaders are a fantastic piece of equipment. You know, you may have issues from the department with regards to cost, but if you look at a complication, for example, of after an osteotomy, you know, loss of fixation, popliteal artery injury, you know, the risks are massive. It's also a good diagnostic tool. Patients who have an offloading brace and they do well with it, it's a very good indicator they're going to do well with an osteotomy. And I've got a few patients who are doing so well with the brace that they're like, well, don't want to undertake the risk of an osteotomy. I'm very happy with the brace. It's obviously a large piece of machinery that's attached to their leg to offload their compartments, but it's an absolutely brilliant piece of kit. And I'll definitely advise people offloading braces certainly is a good thing to do.
And how long would you trial them for?
I'd try them a minimum of 6 weeks, and if they've done well, you know, that's great. And to be honest with you, most people say, "Listen, I'm very happy for the time being," and they just continue with it. There are some people who actually say, "Listen, it's actually made it worse," and you have to think about, you may have to reevaluate the imaging, reevaluate your clinical examination, because those patients may not do well with an osteotomy. Essentially, if they've not got localized medial compartment pain. And a good thing to do before offering that brace is really in terms of assessing their medial compartment collapse. So getting them on the bed, just 10 degrees of knee flexion and just opening up and doing a bit of valgus stress testing. And generally you'll see the medial compartment in their normal state is collapsed, and you're going to open up their knee. And that's what we refer to as pseudo-correctability, to really correct that. And those are the patients who are going to do very well with a brace, an offloading brace.
So Emma's asking if you've got a recommended brace.
Yeah, so there are several on the market. We've tried to start a pathway in Kingston. Obviously, it's all kind of gone on pause with COVID. But there are different, there's a Thursane brace, which is a very slimline brace. Patients really do like it, but it's probably more for mild osteoarthritis. There's an OSA offloading brace, and that is for more heavy duty, probably more for moderate to severe osteoarthritis. And there's also a Medi brace, and the Medi brace, the offloading, which is called the Game Changer. And they're all very, very good braces. So that's the Medi Game Changer, the OSA offloader, and the Thursane brace, which is a French company.
All right, let's have a look if there's any other questions. I may have a question. So if you have a patient that presents to the GP or the first contact practitioner, and based on the history and your examination, you suspect they've got a meniscal injury, how long would you trial conservative management for before you think about referring to you?
So very good question. So for me, it's all in the history. And for example, if I'm suspecting a root tear, I wouldn't sit on them. And the next question would be, how do you know if it's a root tear or a degenerative tear? And it's again all in the history. It's usually more predominantly in females, usually more predominantly in, like I said, the 4th to 5th decade of life. There's a trivial injury. Their knee was normal beforehand. You know, they were going for walks, they're going for jogs, they're playing tennis. They've had this trivial injury. They've had an acute onset. They've had a sudden onset of pain, acute effusions, and essentially they're pointing directly to the medial compartment. That is a root tear until proven otherwise. Slightly is more predominantly in the slightly higher BMI as well, probably BMI, you know, late 20s, early 30s as well. And again, that's all to do with the rotation of the femoral condyle on that fixed posterior meniscal root. With the degenerative tears, there's usually a background of pain with some chondropathy and some delamination of the medial compartment. And, you know, for me, if it's a degenerative tear, I sit on them for 3 months. You know, if they've had a good core rehabilitation program, a steroid injection, the majority of them settle down. But if they've got sharp stabbing, catching and clicking, and again, that's an indication from an MR for me, because if they've got a flap tear, that's not going to improve with an injection or physio. So, and they do very, very well with an arthroscopic partial resection of the flap tear. And yeah, absolutely, that's kind of my pathway. But really, it's all in the history for me.
There's a question from Daniel. Do you think patients can have pseudo-locking not attributable to a meniscal injury or pure mechanical cause? Absolutely.
I think it depends on your clinical examination. I find that the more time you spend with the patient, pseudo-locking can probably, once you distract them and once you're able to examine them in a kind of free environment, then you'll be able to assess if they have actually got a truly locked knee. And if there is concern of a locked knee, you know, EUA, I'm very aggressive with that. If there's any concern with a locked knee in anyone in between, you know, the pediatric age group up to into their 40s, and they've got a locked knee, you know, I take them in for an EUA with a view of scoping and repairing their meniscus. So have a low index of suspicion. Again, it can happen. The locked knees I see generally are truly locked, and patients who generally don't have a truly locked knee, you'll be able to see them on their gait assessment when they walk into your room. You'll be able to see if they're limping, or that antalgic gait, and they're not able to engage their quads. If they've got a truly locked knee, they're going to have quads wasting, because they're not going to be able to engage that fully extended position. So really, I think, I have to go back to the history and examination, so critically important.
Great. And another question that I've thought of thinking about primary care, what investigations do you want primary care to have arranged prior to referring to you, or what would you like reserved for secondary care?
So primary care, again, if you were talking about more kind of progressive arthritis and progression in terms of down that up that curve into the amber phase, I think a full weight bearing series on the x-rays is imperative. I have to say the majority of my patients, the 30s upwards, they get a full weight bearing series of their knee. Obviously, I do a lot of meniscal preservation and osteotomy work, so a lot of them do get long leg x-rays. I would reserve the long leg x-rays really for referral to the specialist centres, because there's certain ways to perform it in terms of rotation and in terms of preventing loss of interpretation of the films. So weight-bearing x-rays would include a full weight-bearing AP, a lateral, a skyline, and the Rosenberg view. Very critical with the Rosenberg view to ask specifically for a view of the joint and to avoid any overlap. You'll get some radiographers who'll just slap the patient into the room, just do the x-ray just to get them out of the room, but you send them back. If there's overlap of the joint, you're not going to be able to interpret that x-ray at all, and it will give you a very good representation of what's going on in the compartment. And really, you shouldn't really assess a knee joint unless you've got all 4 of those radiographs. The majority of my referrals I do send them back to x-ray. They've all had a weight-bearing AP and lateral, but unfortunately you can't make a full interpretation. So from the x-rays point of view in primary care, I think it's more than reasonable to get those 4 initial x-rays, and I would leave the long leg x-rays for specialist interpretation for example, in my centre.
And when would you like to have an MRI prior to seeing the patient, or would you like to assess them first?
No, I'm sure the majority of patients they're going for an MR. I don't see the point in for example, people who've got a 15-year history of arthritis, and I see a lot of those people who have had an MRI scan, and then I just you see it's all bone on bone arthritis in the patellofemoral and tricompartmental OA. With those, I think we need to be pragmatic. Get an x-ray first. If it's again acute pathology, if you're able to, if they're within the pediatric cohort all the way up to their 50s, I think it will make a massive difference for me seeing the patient, because I'll be able to assess the patient, examine the patient, review the MRI scan, and make a surgical decision. And that's why when I do go through my triaging, we triage a lot of GP referrals and internal referrals. I do book the MRI scan based on the information that's fed to me. And if there is something that I'm querying, whether it's a meniscal root tear or a radial tear of the meniscus, or anything that requires anything more invasive, then I book the MRI remotely prior to seeing the patient, because it's a wasted event coming in to see me. I'm going to send them away, have an MRI scan. So I would say have a low index of suspicion. I think when you're getting kind of beyond like the 60s, there's really I think you should be getting the x-rays in the first instance.
Ali is asking, how are you treating isolated osteochondral lesions?
Osteochondral lesions in terms of osteochondritis dissecans, or osteochondral lesions in the adults? Are we talking peds, adult? Which one do you want me to talk about?
I'll wait for Ali to come back. In the meantime, Daniel's asked if more research is coming out for ACL, COPAs and non-COPAs post-ACL injury or rupture, and would you still send all ACL injuries for an ortho consultation?
So I may be quite aggressive. I think patients who, so obviously not everyone who ruptures their ACL has to have an ACL reconstruction, but I think anyone wanting to go back to any form of pivoting sports, in my books, they're getting an ACL reconstruction. I think it's all my ACL patients all go for a prehab program beforehand, and they make a massive improvement. But if you leave them for a couple of years, and I've got a collection of these in my database, there will be one episode where they're twisting, they're turning, and they twist, turn, rupture their meniscus, tear it, and then that's it, game over. So really, if you counsel them and they want to lead a sedentary life, and they're happy not going back to football, rugby, they're quite happy, they've got an office job, they've got kids, that's absolutely fine. You rehab them, they'll do absolutely fine. They'll be able to go back, go for odd holidays, skiing, with a brace, etc. But people who are going back to high level of activity, I think it's very important, as long as they're counseled that they've got a high risk of chondromeniscal pathology, which may be detrimental to that compartment, and they understand that, then you can certainly treat it in that way. But in my books, if they're young and they want to get back to pivoting, twisting activities, it's an ACL reconstruction.
So Ali hasn't come back, but the second part of her question about treating isolated osteochondral lesions was, are MACIs still being done? So that.
Okay, so more in the adult population. So again, you go back to that ladder, that one of my first slides. You make sure that the alignment is correct. So again, if there's an isolated chondral lesion, I just ignore the chondral surface. I go straight to the alignment. I clinically assess their alignment. If they're in varus, they're getting an osteotomy before even touching the chondral surface. You have to make sure the knee's stable. If they're ACL or PCL deficient, they're going to get a simultaneous osteotomy with the ligament reconstruction. Once the limb alignment is corrected and it's a stable platform and the meniscus surfaces are fine and they've still got pain, then they're going to get a chondral treatment. Whether that chondral treatment may be a chondroplasty, where we can just tidy up the edges of the chondral surface, or whether I abandon microfracture or abrasion therapy, that's all very much in the past for me. Microfracture does not work, and it muddies the water for any patient who requires anything further. And I think really the gold standard with any significant chondral defects is osteochondral allograft transplants. And that is again, big operation, but more often than not, once you've corrected their alignment, you've got their knees stable, they've got good meniscal tissue, it's very rare to actually require to do that.
Any other questions, anyone? I think that might be all of our questions. Thank you very much, Mr. Dabbas.
No
the
problem.
Brilliant talk. We will share the video with everyone as well, so you'll have access to the video afterwards, and if Mr. Dabbas is happy to share his slides with us, we can share that with you as well. And also we'll be sending you a feedback questionnaire if you wouldn't mind filling that in. It's really helpful to see what we can do in the future. And then we will also send you a CPD certificate for attending. So thank you, everyone. Hope you enjoy a lovely evening, and we'll see you at the end of April for the shoulder. Take care.
Thanks, everyone. Cheers.
Bye-bye.